Welcome to Learning Thursdays. My name is Crystal Hewitt-Gill with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Part 1, Medication Self-Administration with Staff Oversight. Our presenters will be joining us in just a moment, but first a word about Learning Thursdays. Learning Thursdays are a program offered for free to behavioral health professionals as a learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce, as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. One goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox indicated on the PowerPoint. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now, it's time to start the presentation, so welcome to our presenters.
Hi, I'm Michelle Falkowski, the Director of Nursing for New York State OASAS.
Hi, I'm Debbie Eagle, and I'm a nurse and an attorney for OASAS. And we're now going to introduce the two new Train the Trainers.
Hello, my name is Patricia Roberts, and I'm with Helio Health.
Hi, I'm Ingrid Hansen, and I'm with Helio Health.
So I just want to begin by saying thanks and welcome to the training. This is Part 1, Medication Self-Administration with Oversight. Part 1 reviews the revised LSB that was issued in March of 2019. To give a broad overview, the legislature creates laws. Mental health covers OPWDD, OMH, and OASAS. In order for the agencies to interpret those laws, they write regulations. As you know, you're probably in a Part 819 or an 820, and you're guided by those regulations. We also put out local service bulletins to help with specific issues. If you go to the website, under the tab Regulations, you can click it, and there's a drop-down box that says Local Service Bulletins. That's where you will find this local service bulletin. So, in 2012, Michelle and I went to visit programs across the state that were known as 819s. At that point, we had written the original LSB because we wanted to help staff to be educated about how to oversee medication administration. And we wanted to help patients become self-sufficient. Since that time, we've had Medicaid managed care reforms, we've had the Justice Center, and so as a result of that, we needed to update the local service bulletin in regards to medication self-administration with oversight. We put out a new LSB, and Part 1 goes over what that LSB contains. The objective of the LSB is to provide structure in the 819 and 820 programs so that we can deliver self-administration of medication with oversight. The LSB lays out the details of what policies and procedures are needed for compliance with the LSB, such as who can train the staff and who can oversee the staff and more. Okay, so now I want to go over some definitions. There are 3 things to take into consideration when you are dealing with medications. The 3 words are dispense, administer, and self-administration. These words define what staff can take on these tasks and who can do what. If staff operates outside these parameters, there could be legal ramifications. As the words are often used interchangeably, we want to address the meaning to clear up any confusion and to avoid any negative consequence. Now, I'm going to take a few moments to allow you, the virtual audience, to consider your staff. Who do you think on your staff is legally allowed to dispense, administer, self-administer? Think about that for a few seconds, and then we will define for you who is legally allowed. Okay, so now that you're thinking about it, we're going to tell you who can dispense. Pharmacy, refers to the preparation and dispensing of drugs, as well as the counseling of patients in the proper use of these drugs. Pharmacists, physicians, physicians' assistants, and nurse practitioners all can dispense. Pharmacists and physicians can change labels on a medication. Make a special note, RNs and LPNs cannot change medication labels. Also take note that medications prescribed for one patient should not be used with another patient. Who can administer? In New York State, only appropriate licensed professionals are legally allowed to administer, which means hand medications to patients outside of their bottle, blister pack. So that would include, in our settings, RNs, LPNs, NPs, PAs, physicians, and in limited circumstances, even pharmacists. What is administration? Medication administration can be broken down into its component parts that are necessary to ensure 1. The right patient receives the 2. Right dose of 3. The right medication, and 4. At the right time, 5. In the right way, and that 6. The right documentation is done after the patient received the medication. 7. For the right reason, and 8. Experience the right response to it. However, we want to make note that there are 2 carve-outs in the law, and we're telling you about them, but neither one applies in OASAS. So in New York State, there is a carve-out that New York State Nursing Association has been fighting against for years, and that law allows for RNs who work in OPWDD to train non-nursing personnel to administer medications. This training is the Approved Medication Administration Personnel Training. They call it AMAP for short. This teaches non-nursing staff to administer medication, but in community residences only. That's because these are their homes. This is where they're living. Another new law allows registered professional nurses to assign advanced home health aides to perform advanced tasks for certain home care and hospice patients. This law requires advanced home health aides to perform these assigned advanced tasks under the supervision of an RN. Okay, and now we get to what we actually are doing in OASAS, self-administration. So who can self-administer? Well, competent patients can self-administer their own medications with staff overseeing this process. It was determined by OASAS that licensed professionals, along with CASACs and CASACTs, are qualified due to their education and professional accountability. I want to make a special note that pharm techs are not licensed professionals and can only work under the auspices of a pharmacist. Pharm techs are not recognized by the OASAS LSB as individuals who can oversee self-administration. The goal is to teach patients to be self-sufficient within a safe parameter. Staff oversees the medication self-administration process and ensures that the patient is learning to take the medication the right way with the 8 rights, meaning at the right time, right route, for the right reason, and basically that they understand their medications and that it's important for them to take it. We're trying to teach them this in a safe environment. The goal of the 2019 Local Service Bulletin was a revision to expand self-sufficiency. It's important for patients to learn that it's important to their health to take their medication and take it the right way. This will help them to stabilize and hopefully extend their recovery. The titles listed above are the only titles that OASAS recognizes as staff in the OASAS system that can oversee patient self-administration of medication. The Local Service Bulletin designates that only a registered nurse can train non-nursing staff. In order to be qualified as a nurse to train non-nursing staff, if you're an RN working in a provider program, you must first take this webcast and pass the post test. Once you pass the post-test, you will be able to provide proof of this, and then you will be allowed to register for Part 2. Part 2 is an in-person train-the-trainer that will educate RNs how to go about teaching non-nursing staff what is required of them to oversee self-administration of medication.
The LSB lays out the policies that providers must create and follow. Only RNs can take the train-the-trainer training, Part 1 and Part 2. Only RNs can determine who is competent. Only RNs can disqualify staff from oversight. Providers must conduct ongoing quality assurance monitoring for all activities. Part 2 of the training will focus on training staff and how the program can implement this. A change to this LSB is specific to youth residential providers. If the child is under the age 16, a nurse must administer the medication. OASAS providers should have a procedure to evaluate children in youth residential programs for their ability to self-administer with oversight upon admission. A procedure must be in place to reassess the child in cases where the child exhibits any changes which may indicate they are impaired. OASAS guidelines and policies indicate that a provider must write an order that the child is self-directed and may self-administer medications that have already been dispensed by a pharmacy. Appendix XII is an example from the Part 2 training of how this can be done. Children under the age of 16 do not have the requisite age of consent. Therefore, they may not understand the ramifications of their medications. Mother and children programs should have their policies and procedures as well, because the parent's child is not considered a patient of the program. Policies and procedures should include where the child's medication is stored, where it is documented to show that the medication was given to the child. A child for this purpose is defined as being 5 years or younger.
So, for instance, if you have a program where the mom has her children there, we recommend that the medication is stored in the medication room. Because the child is not a patient, we believe that the best practice would be to create some kind of documentation. The mother comes down with the child, the staff hands the medication to the mother gives the medication to the child, and then the child takes it and somebody signs that they watched this process. The staff cannot give it to the child because the child is not a patient.
The 8 rights of medication administration apply to staff who are overseeing a patient self-administer their own medication. If one of these 8 rights is not correct, staff must be knowledgeable of the facility policy as to how to address and to correct. Programs must have policies and procedures that address both prescription and over-the-counter medications that are ordered by a medical provider. Please take note that some facilities will utilize a paper MAR while others may use electronic health care record. When you're teaching these facilities, there are special considerations to note for both of these. A paper MAR will have handwritten documentation, where the electronic health record may have more of an electronic signature. Also, please take in consideration if it's a stat order or a PRN, how that is documented on a paper MAR. Providers' policy and procedure should outline each of these considerations. Staff trained by RNs should demonstrate competency of providers' policy and procedures. When creating policies and procedures, these are things to consider based on the type of patient record your provider uses. For a paper record, if you have multiple people that are required to take medication, how do you know a patient actually took their medication? How do you document if a patient did not take their medication? For PRN medications, how do you remember to note the effect of that medication? And how would one discontinue a medication that is no longer being ordered? For electronic health records, typically they will have electronic alerts and the ability to do overrides and to discontinue medications.
Consistent with the last local service bulletin, oversight does not allow staff to pour a liquid or hand a specific dose of medication to a patient. The New York State Education Department issued a practice alert about the delivery of medications to individuals in the community setting, where they said it was appropriate for non-nursing staff to read the label for visually impaired patients, remind a patient to take a dose of medication at the right time, take a cap off a bottle, or open the back of a medication card, but do not remove the pills for individuals who are incapable of opening and removing the medication. OASAS recommends that non-nursing personnel do not assist in filling a syringe of insulin. Staff should also be able to identify signs that a person can no longer self-administer.
To give you an example of what that would look like so that you can understand it, is there were actually staff at one of the facilities, and it was night staff coming into day staff. The night staff told the day staff that the person was responding to internal stimuli. The day staff didn't know what that meant. They didn't ask a question. But as the morning progressed and the night staff left, it actually meant that the client was having hallucinations. The client then began to act out because they were decompensating, and they had to call the police and an ambulance as an endangered person and had to have the patient removed. Maybe some of that could have been resolved had there been better communication. But as staff, because we're allowing clients to self-administer, we have to have a good communication, and we, as the staff, have to understand and teach the non-nursing staff what they should do when they think somebody's decompensating. So they're not going to evaluate the patient. They don't have that skill set potentially, but what they're going to do is call the nurse, call the PA, call the doctor, call somebody, call the director and say, look, this patient is talking to themselves. What should I do around their medication? Should I give it to them? Should I hold it? Can we bring them over to the clinic? What should I do? And that's part of what the nurses are going to teach the non-medical staff, how to respond to a patient that is decompensating. This is the appendix that is part of the materials that you will get in Part 2 that addresses the things that Michelle just spoke about.
In reintegration and supportive living, patients in scatter sites do not need oversight as they are in their own apartments. Providers must write policies on how medications are stored and secured. An example of why safe medication storage is important is a recent incident where a patient allowed a friend to shower in their apartment. Her friend stole her 43 strips of Suboxone. Fortunately, as she filed a police report, her prescriber was able to write a new prescription for her. Obviously, the provider did have a method for the patient to secure their medication. They chose not to follow it. So there should be some oversight periodically to ensure that patients are indeed in these settings storing their medication appropriately. Now that you understand some key points of the LSB in regards to medication self-administration, you need to understand key points of medication disposal. The New York State Department of Health Bureau of Narcotic Enforcement and the New York State Department of Environmental Conservation have different regulations on disposal. New York State Department of Environmental Conservation regulations do not apply to controlled substances. Providers must be aware of both BNE and DEC policies and should seek compliance. Provider policy must include proper handling, storage, and disposal of all pharmaceuticals. Policies should also include regulated medical waste. This would include sharps disposal and red bag waste.
Medication storage. Consider the access to medication keys. Keys should be limited to staff assigned to oversee the self-administration and do the controlled substance count on each shift. Best practice is to have one staff assigned the keys and count. At the change of shift, outgoing staff count with incoming staff together and hand off the keys. Providers need to take special considerations for narcotics that need to be stored in a refrigerator. For instance, Sublocade is a subcutaneous buprenorphine product. It may be stored in refrigerators in your setting, although I will note that Sublocade should never be self-administered. Some considerations for refrigerated controlled substances are double-locked refrigerators and additional considerations, including a New York State Department of Health Class 3A limited license. When it comes to medication storage, the LSB designates what is okay for patients to keep in their room. It is limited. There may be special consideration for EpiPens. Consider this question. Can non-medical staff administer preloaded auto-injecting epinephrine doses or EpiPens to clients who are undergoing anaphylaxis, a severe allergic reaction, in an OASAS authorized or certified treatment program, including residential settings? The answer is yes. That is permitted under the education law. As per the Exempt Persons section of Education Law, Article 139, Section 6908, Exempt Persons. This article shall not be construed as prohibiting the furnishing of nursing assistance in case of an emergency. Non-medical staff may be trained to administer the epinephrine. Additional information on epi auto-injector devices, orders, and training requirements, possession and use may be found on the OASAS website. Providers should have policies and procedures that address ways to manage without dispensing. As you recall from earlier in the presentation, we are not dispensing in this setting. Pharmacy provides individual medication packages. Patients may carry individual doses. However, there are potential concerns with this, including tamper-proof packaging, child-resistant containers, as well as the labeling.
So when a patient is going off the unit for a pass, you have to figure out how they're going to carry their medications. If they're walking with the pills in their pocket and they get stopped, they may have a problem. These are the things that the provider has to figure out when the patient is leaving the unit.
Staff and patient training and orientation. This information will be taught in Part 2 of this training, but the LSB requires providers have policies and procedures that address RN training staff has the ability to disqualify staff from the task of overseeing patients' self-administered medication. As the staff are overseeing the process, were trained under the RN's license. Article 28 clinics may have nursing staff available to oversee the process and may choose to medicate patients at the clinic. In the case of a paper MAR, have a policy and procedure that states staff signature indicates a staff member oversaw the patient self-administer his or her medication. There are some facilities that may have a patient sign. However, since staff is ultimately responsible, OASAS recommends staff signature on the MAR. Include this requirement in staff evaluations, job descriptions, and build it into the program so it is an expectation of the role.
Finally, it's important to mention that some medication incidents may be reportable under OASAS Regulations Part 836. It's important to know who is a mandated reporter. A mandated reporter is a custodian or a human service professional. Human service professionals include licensed professionals, CASACs, and CASACTs, who under this LSB are the individuals who can oversee patients self-administer their own medication.
The LSB will be posted along with this PowerPoint, and what we tried to do today is provide some information about what the LSB says, because Part 2 of the training is completely based on the LSB. We have some additional resources on this slide that you may find helpful. And you can always ask the trainers, or you can email the nursing email website.
Thank you for participating in this webcast. As a reminder, you are required to take the post-test for this webcast in order to register for Part 2 of this training. To register for Part 2, provide proof of passing the post-test to the Helio Health Training Institute. Contact information is on the screen.
We just want to thank you, our virtual audience, for tuning in today. We hope you found this helpful. Again, Part 1 goes over the LSB, and Part 2 is the hands-on training, and we're looking forward to seeing you there. Thanks.
Thank you.
Thank you.
I would like to extend a special thank you to our presenters for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is highly important to us, and it helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website. and take a moment to complete the evaluation. Once again, thank you for joining us, and keep up the good work.